Hello everybody, and thank you for joining us at the Let's Talk About Pain and Psychology session offered through Gold Coast Health as part of the National Psychology Week 2020. Your presenters today are Jan Turner from the Queensland Pelvic Mesh Service, Colette Morris from the Neurosurgery and Orthopaedic Physiotherapy Screening Clinic, and myself, Margaret Vandermoss from the Interdisciplinary Persistent Pain Centre. So firstly, we would like to acknowledge the Yugambeh speaking people on whose lands we all live, work and play, and we pay our respects to elders past, present and emerging. We have a very brief session today. It's only 45 minutes, so we're going to be providing a snapshot, an overview of pain, looking at the difference between acute and persistent pain, looking at the different types of pain, and then probably more importantly, looking at what you can do differently when you're doing that initial assessment with patients. So looking at a biopsychosocial assessment and offering some information about the types of questions that you can ask to elicit the most valuable information. We're then going to look at how we would introduce interventions to our patients, some of the metaphors, analogies that we will use with patients to help them understand better why we're suggesting certain interventions or why we're asking certain questions. And then we're going to have a brief look at the link between pain, stress and psychology, how we can intervene and how we can improve the overall experience of pain for our patients. We're going to leave you obviously with this very short session with a lot of resources, so you're welcome to pursue looking at information further in your own time. Now, without any further ado, I'd like to introduce Jan Turner. She's an advanced clinical psychologist from the Queensland Pelvic Mesh Service to talk about Explain Pain.
Hi everybody, my name's Jan. I'm the advanced clinical psychologist for the Queensland Pelvic Mesh Service. The service is a statewide service which opened up in April this year, and it's mainly for women who've experienced pelvic mesh complications following mesh insertion for incontinence or prolapse. It's an MDT team, so we have clinical nurse consultants, surgeons, allied health, and of course the administration team. The women receive appointments with surgeons, and they undergo further assessment, with some patients undergoing mesh removal, while others opt for a more conservative approach. The majority of the women have ongoing pain associated with the mesh complications, and they have complex comorbidities. Depression, anxiety, and stress are predominant features, and we use the biopsychosocial model and with innovative pain management interventions as well. So now I'm going to talk a little briefly about the definition of pain and the different types of pain, and yeah. So what is pain? An unpleasant sensory and emotional experience, and it's associated with actual or potential tissue damage or described in terms of such damage. And this definition is from the International Association for the Study of Pain. There are three main types of pain. The first is acute pain. So that lasts generally for a short time, usually 3 to 6 months. And I guess the timeline there is related to how long the body needs to heal internally. Usually by the 3 to 6 months timeline, most of the injury has been healed. And it usually occurs after surgery or a trauma or some other kind of condition. It acts as a warning to the body to seek help, and it improves as the body heals. Recurrent pain is pain that can occur on a cyclical basis, like migraines or pelvic pain. And subacute pain is pain that's progressing towards chronic pain, but this progression can be prevented. This is known as the transition phase. And finally, we have chronic pain. So pain that lasts beyond the time expected for healing, so usually between that 3 to 6 months, following surgery or trauma or another condition. It's often associated with an increase in pain experience, not just in the area of injury, but also in surrounding tissues or nerves, and it can exist without a clear reason. Just want to briefly talk about the different types of pain. So nociceptive pain arises from various kinds of trouble in tissues, and it's reported to the brain by the nervous system. This type of pain everyone is most familiar with. Everything from a bee sting to burns to stubbing your toe to repetitive strain injuries, nausea, tumors, and inflammatory arthritis. Nociceptive pain typically changes with movement, position, and load. Nociplastic, the new mechanistic descriptor, is defined as pain that arises from altered nociception despite no clear vision of actual or threatened tissue damage, causing the activation of the peripheral nociceptors or evidence for disease or lesion of the somatosensory system that's causing the pain. And neuropathic pain is initiated or caused by injury to neural tissues in the central or peripheral nervous systems. Neuropathic pain can sometimes be difficult to identify. It can be an area where there is no feeling. Patients often complain of spontaneous pain and pain from stimuli that are not normally painful, like a slight breeze or a light touch. Neuralgia is one example, diabetic neuropathy is another, and phantom pain. Now I want to talk to you about the nervous system, because basically the more we learn about pain, the more important it is to be aware of how the nervous system interacts with the pain experience. So nerve pathways carry messages from specific areas of the body via the spinal column and up to the brain. It's there that the brain determines whether it's a threat or it equals danger. The brain then returns a neural impulse to the original site where the person then experiences the pain. Other areas of the brain that control pain also control our emotions, like sleep and our hormones. Emotion, sleep, and stress all can have an adverse effect on pain. Central sensitization is a condition of the nervous system that is associated with the development and maintenance of chronic pain. When central sensitization occurs, the nervous system goes through a process that's called a wind-up, and it gets regulated into a persistent state of high reactivity. And I want to talk a little bit about the brain and pain. And I think it's important to be aware that the brain really is the controller. And I've got some slides here that I just want to show you, which will make it a bit more sense. So here is a picture. This is from a really good website called Neuroplastics, and there's a lot of research being done on the effects of the brain and pain. So here's a photograph of a brain when the patient or the person is experiencing no pain at all. As you can see, there's no highlighted areas lit up on the brain. This picture shows you the brain and a person experiencing acute pain, and you can see from this slide that there are various areas of the brain that are lit up when a person is experiencing acute pain. So it's not just from one area. This slide shows you the brain when a person is experiencing chronic pain, and you can notice that the activation of the different parts of the brain is much larger when the person is experiencing the chronic pain. And interestingly, here is a picture of the brain when the person has depression and chronic pain. So you can see they're further accentuated on that picture. So I guess that's why mood is a really important aspect to consider, along with other emotions that the patient feel, because that can have an adverse effect on the intensity of the pain that the person feels.
Once upon a time, all the lands were fraught with persistent pain. So widespread was this affliction that 1 in 4 people experienced it. The pain lasted for more than 3 months. It shadowed their daily lives, held them back from everyday activities, and the interventions they tried proved useless. Hey, pain, go away, we've tried it all, but still you stay. Moving less, taking pills, knives and needles, and still we're sore. We can't take no more, no more. But the pain remains like a loyal companion. The people's hopes faded, and they became resigned to living with the pain. Only now the pain was a beast. Then along came a group of researchers, of which I am one. Back off, big fella. I'm Professor Lorimer Mosley, and I'm a pain scientist. Pain scientists are starting to think differently about pain and its causes, and we're making exciting discoveries, like how the way you think about your pain can change the way it feels. Over the next few minutes, I'll help you to understand your pain. Understanding is important because it can change how much things hurt and how much your body can do, and it can help you to tame the beast. First, trust me about this. Pain is not an accurate measure of tissue health. Pain is a protector. By making unpleasant feelings, your brain changes your behaviour so you can avoid injury or your tissues can heal. Sometimes pain is not helpful, like phantom limb pain. You don't expect a missing limb to ache, but it does, and the pain is very real. So how do we explain this? Well, pain is a warning signal from your brain that depends on credible to say your body needs protecting. Sometimes pain's too protective and you get unnecessary warning signals. Pain scientists now understand that there are many ways our nervous system ends up producing unnecessary warning signals. Take conditioning, for example. You think of Pavlov's dog. Every time food was offered, Pavlov rang a bell. Of course, the dog would salivate seeing the food. This went on for a while. Eventually, the dog was conditioned to salivate for the bell alone. Well, conditioning is just one of the ways your body learns pain. And the longer your nervous system produces pain, the better it gets at producing it. Your body learns pain. So what feeds this beast? Well, let's look at how pain works. In your body's tissues, there are specific neurons which normally only respond to harmful stimuli, whether mechanical, chemical, or thermal. When they are activated, they send a warning signal to your spinal cord, which can in turn send a signal to your brain. This activity in neurons is called nociception, and it's happening all the time, but only sometimes results in pain. Most of the time, the brain protects you with other things, like movement. Once the warning signal reaches the brain makes sense of it based on the information arriving and a vast amount of information already stored. If there's good reason to think protection is required, then your brain makes pain. One of our amazing discoveries is that you can have pain without any physical stimuli. Thoughts and places might activate the warning signals, and the pain feels exactly the same. But it's not just your brain. Your spinal cord also learns how to generate unnecessary warning signals. So how do you know when your nervous system is learning pain? You may notice your pain spreads or comes on without warning. Your body feels odd and it's hard to move properly. Your pain changes quickly with your mood, and small annoyances can set it off. Old injuries start to hurt again. You're more sensitive to stimuli, and the longer the pain goes on, the more all of this occurs. The old way we understood pain could not explain these things and left many sufferers feeling like no one believed it was real, or for it to hurt so badly, there must be a major tissue problem. But we now know how persistent pain happens. So how can you tame the beast? Pain is a very personal thing. There's no one-size-fits-all solution. And while you probably have well-thought-out coping strategies, it's time to take a new approach to dealing with and reducing your pain, one that focuses on retraining your pain system. This might mean testing yourself physically and moving more than you normally would. Being honest about your current attitudes and beliefs can also help, as can asking your health professional new questions.
How do I know if my pain system is being overprotective?
How do I retrain my pain system to be less protective?
How do I know if I'm safe to move?
So be brave and have hope, because it is possible to tame the beast. Visit our website for more information and questions to ask your health professional. tamethebeast.org.
If you'd like to learn more about chronic pain, there are some good resources from the Neuro Orthopedic Institute, which is noi.com.au, and that's run by Lorimer Mosley and David Butler, and they've produced a number of really exploratory books on explaining pain, and they've also they also do online courses, and for next year there is 15% off their online courses, so if you're interested in that, please check that out.
Hi everyone, my name's Colette Morris. I'm a health psychologist. I'm working in the neurosurgery and orthopaedic physiotherapy screening clinic at the Gold Coast Hospital. So our service is mainly around helping people to cope with various musculoskeletal issues and chronic pain in general. So patients are generally referred initially from either the neurosurgery or the orthopedics specialty into our service. So they're screened and then referred to us if surgery is not indicated, or they think that they benefit more from the conservative management approach to their condition. So we work as part of a multidisciplinary team. So we have physiotherapy, psychology, dietetics and pharmacy. And so we also run group education programs, so more looking at exercise programs, pain education, and a health promotion group as well. So the focus of the psychology team is helping people to manage their pain better from a psychology kind of perspective. So looking at any barriers to managing their pain better too, and any mood concerns as well. So our main approaches are more the cognitive behavioural therapy, acceptance commitment therapy, a lot of psychoeducation and motivational interviewing as well. So today I'm going to talk to you about assessment of pain and what kind of questions and tools and areas and things that we want to look at when we're assessing a pain picture. Okay, so you might remember this industry super ad from TV. So we're going to compare the pair. So we have two men here. They're the same age. They may have the same injury, say like a chronic lower back pain, but they have a different pain. So although two people may have the same injury or illness, their experience of living with pain can be vastly different, because pain is such an individual experience. So when we're starting with an assessment of pain, we first have to focus on the person that's in front of us here too. So some kind of quotes from Catherine Glore. So she presented this at the Virtual Pain Summit this year. And she's kind of saying that I'm not a collection of body parts and diagnostic herds. I'm one unique human having a unique pain experience, and my pain is an authentic experience. And I'm not your 3 o'clock elbow appointment, I'm Kat. So it's really, again, really important to focus on, firstly, the person that's sitting in front of us, and that too, and looking at them as a holistic person. So we know that chronic pain doesn't just involve a biological or anatomical systems, and it can also be affected by and affect psychological and social factors. So we really need to take this biopsychosocial pain assessment approach, and we'll look at each of the factors a bit more closer in a minute. Also too, what we need to remember is, you know, before we're seeing this person is to do our own investigating. And we need to kind of look at, you know, if the person has medical records, having a look at and what kind of can we gather before we see the person. One of the things that, you know, people do say is that they hate repeating their story over and over and over. So if we kind of take an interest and we do a bit of investigation prior to that, that kind of helps just build that trust and rapport, which is really important in this work. So looking at biological factors, so what kind of areas are we going to look at? So we want to know about, I guess, the site of pain, and there is this kind of numerical rating system that I'll get to in a minute as well. When we're rating pain, we want to know how long the pain's been there for, how bothersome is it in the person's life. Looking at flare-ups, so how do they manage the flare-ups? What do they do? Do they kind of, you know, lie on the couch for a couple of days afterwards, or do they try and, you know, do some gentle movement and that kind of thing? How much of an impact does it have on their life? What medications are they been on? Are they on opiates? How long have they been on them for? And how effective do they find them as well? Also coping efforts. So what have they tried to get rid of the pain? You know, it's really common that you'll see people that have tried everything: acupuncture, massage, surgery, injections, everything like that. And sometimes they haven't, you know, varying levels of effectiveness too. So what have they tried? Also looking at kind of the comorbid symptoms that go with pain as well. What's the effect on their sleep, fatigue, daily functioning, concentration, memory? All these things can be affected by pain, and also can be side effects of pain medications and things like that too. Then we can also kind of look a bit further into other body systems and what's going on there, particularly with the immune system reaction too. So if we've got you know, some autoimmune issues or things like that, that can kind of also help to you know, build insight into with the patient to see that other body systems are also in this kind of really overprotective, overstimulated kind of mode. Okay, so we often kind of hear, you know, health practitioners ask patients or people with pain, you know, can you rate your pain on a scale from 1 to 10? So generally have this nice, you know, measure here, 0 with being no pain and 10 being the worst pain possible. And again, Catherine Glor from the Virtual Pain Summit is talking about, you know, scales and how really, you know, not helpful they are as well. Because so she's saying, when I'm told to imagine that 10 is the worst pain imaginable, I have a pretty good imagination. So I'm never going to rate my pain as 10. So, you know, and what the person understands the numbers to be will be different to what the health practitioner or you understand the numbers to mean too, because they're so subjective. So asking me to define my pain on a 10-point scale is like pointing in a river and asking me to describe it as wet, very wet, or super extra wet. Sure, you might get a quantifiable measure, but you still have no idea of its source, its path, or its very nature of being. So again, there's plenty of, you know, lots of different ways that we can assess pain, and I'll go into this in a moment. Okay, so just an excerpt here from a journal article by Miller, Eldridge and Dalton. So looking at nurse-patient communication and patients' explanations of pain. So patients also say that they may feel reluctant to communicate with providers about their pain levels. So this may be due to the patient's fear of bothering the staff, the belief that nothing will help their pain, age-related stoicism, fear of not being believed, and a lack of common language in which to discuss pain too. So this is really, you know, common, you know, issues that particularly when you're working on the wards in medical kind of settings and that as well, you do really see this a lot as well. So we really need to be mindful as health practitioners around this. Okay, so looking at the social factors as well, pain has a huge impact on people's lives, particularly in the social kind of realm. So a lot of people, unfortunately, you know, do have to give up work or study because of the pain, and that too. And as we know, work and study and what we do is such a huge part of people's identity too. So people really can struggle with that adjustment too. And then again, the resulting kind of financial stress with that too. And issues with, you know, Centrelink or insurance and things like that too can be a real stress on the person, then again, and translate into, you know, further winding up of the nervous system and can create more pain as well. That being said too, even, you know, things like work cover as well, you know, lots and lots of stress associated with that process and that too, which can be really upsetting for the person as well. Also looking at, I guess, and how pain affects friendships, relationships, and that as well. Are they still able to get out and do things with their friends and that as well? Or have they kind of been more reclusive and isolating? It's also nice to kind of, you know, ask the person and kind of almost flip it and say, well, what do you want to get back to doing? You know, before all of this, what kind of person were you? What did you like to do? Asking these bigger questions, what's important, what's meaningful to you, you know, is, you know, going out and, you know, going down the beach with your kids, is that important? Or is it kind of getting back into a social or a sports group or something, or, you know, a hobby group or something like that? What's really important and meaningful and valued to you, and how can we kind of make a bit of a plan to get back to that? Also a nice one to think about too and ask is around, how do others react when you're in pain? Often we have, you know, well-meaning family members and friends that might say, oh, it's okay, go down and sit and rest when you're having a flare-up or when you're in pain. But sometimes that cannot be very helpful in itself too. So, you know, do people overreact? Do people underreact? And that we do feed off each other's energy in that too. So it's really good to kind of know how the family and friends react and think about pain as well, what kind of messages they're sending. Okay, so the last section we're going to look at is the psychological components. This is a really important part when we're in our pain assessment. So we want to know what have they been told about their pain and who from? Is it from, you know, surgeons, other doctors, other health professionals? And what did they say? You know, is it something that's going to get better, something that's going to get worse? Do they need surgery? Do they not need surgery? So that's going to be really important to know. We also want to know, what is the person's theory about their pain? What do they think's going on with them and their body as well? What do they think they need? And also their beliefs about their timeline. How long is this going to go on for? What kind of treatment do they need? Other things like that. Another part is the trauma history as well. This is a really important part, and obviously assess this because it can be obviously a sensitive nature, and assess this as appropriate too. So we want to know, you know, is there any history of trauma or significant life changes in the person's life because of the effect of trauma on the nervous system? And obviously when we're talking about chronic pain, it's, you know, also involves the nervous system and oversensitivity. It's really easy to see how those two can be linked. Also looking at the effect of your pain on mood, and then how mood also affects pain too. So it's a really strong bidirectional relationship. Also be on the lookout too for any unhelpful messages, you know, that might come from well-meaning friends, family, other health professionals, things like that. So things like, it'll only get worse as I get older. I'll have to end up in a wheelchair. You know, I'm worn out. I just need to rest. I can't do anything when I'm in pain. I'm stuck like this forever. So these are really unhelpful messages, and they don't kind of help to empower the person. So we need to be very mindful of how they think about their pain too, and address, you know, use our intervention to address some of those too. Okay, so also looking at these other kind of areas which are again really common in chronic pains, looking at fear, loss of control, self-doubt, isolating or isolation from others, confusion, depression, loss of hope. Really, unfortunately, very common themes with people with chronic pain. This is why it hurts. So we have the multimodal assessment model of pain here, and this is models here by Dr. Timothy Weidman. He's a physical therapist and assistant professor at the McGill University in Montreal. So he's looking at kind of, you know, things to look at when we're assessing pain. And what we really need to focus on, I think, as clinicians, is this pain experience, which in the middle of this sphere here is what you can't exactly see from the outset, and that too. So really need to focus in and draw that out from the person. And then on the outside here, we have the pain narrative and as well, and then the pain behaviours that kind of go along with that too. And almost kind of less focus here, which is still important, but almost maybe we should focus a little bit less on this kind of self-report measures and that here on the outside. And this all exists within, you know, a certain environment too. So again, the focus here that I think we can all take away from this is looking at and understanding the pain experience, which again is not the first thing that we might see when we see the patient in front of us. So in all of this too, we have to remember the patient is the expert. So do we take a patient history or should we receive the patient history? So really the importance of listening is so crucial. So learning to listen more and talk less, and receiving is done when you're silent and receptive. Okay, so again, a little bit more, some other questions and things that you can ask here from this journal article by Dina, Cargella and Lau. So look at these in more in-depth questions. So things like, you know, what gives you hope? You know, where do you see yourself in 3 years in regards to, you know, your knee pain or whatever? What do you think it's going to take you to get better? Okay, just very quickly, some psychometric measures that you might be able to use as well, and these are all freely available on the internet too. So the first one's the brief pain inventory. This is a 9-item scale, so it measures the severity of the patient's pain and the impact it has on their daily functioning. The next one is the pain self-efficacy scale. So this has got a 10-item measure. So this is measuring confidence to perform activities despite having pain. And the last one here is the pain catastrophizing scale. This is a 13 items measuring pain catastrophizing. So looking at ruminating, over pain, magnification of symptoms and helplessness. So the more emotive kind of component. So the 3 measures, really quick, simple to use and can give you a lot of good information. So now I'm going to hand over to Margaret Vandermos. She's a senior clinical psychologist at the Interdisciplinary Persistent Pain Clinic here.
Hello again. So my name is Margaret Vandermost, a senior clinical psychologist from the Interdisciplinary Persistent Pain Centre. We are a specialist outpatient service for people with persistent pain. So our mission at IPPC is to inspire hope and get people back to living a valued life through effective evidence-based pain management. We have multiple entry pathways into the clinic here, allied health and medical, and we're very proud of the fact that we see all patients within the required wait times based on their category. Our team is a multidisciplinary one, so we work on shared patient goals and from a common supported self-management rehabilitation model. We utilise acceptance and commitment therapy as the main modality, talking to people about their values and really trying to help them relink with what's important to them. So based on everything you've heard so far, it's pretty evident that pain alarm sensitizers are multifactorial. There's a number of things that contribute to someone having increased pain and for their central nervous system to become more sensitized. And it can be as simple as sleep deprivation, not sleeping due to the pain or worry associated with the pain, but it can also be more subtle things like words that people have used to describe their pain, health professionals potentially predicting further disability down the track. Our words that we use with them that might be fearful. It might be a diagnosis that they don't quite understand. So fear, beliefs, poor belief in their own ability to manage despite the pain, all of these things can contribute to an increased sensitivity in the nervous system. The good news is that because of that, these are all modifiable. So if we think about the opposite of those things that are causing sensitivity, if we choose our words wisely, if we work out the patient's belief system and we help educate them and reconceptualize those beliefs, if we engage them in group activities to reduce their social isolation, if we do sleep hygiene with them and improve their overall sleep quality, all of these things improve their psychological health and improve their pain experience. So what are we going to do first with our patients? This is a beautiful slide from Kat Glaw, CRPS advocate that we've utilised throughout this presentation. And she writes, seek first to understand and the outcomes, the ones that matter to me, will follow. So we're really focused on what the patient wants out of the interaction with you, not so much the outcomes that we're looking for, but what's important to the patient. And another pain advocate with CRPS, who calls herself the Princess in the Tower, actually put a quote on Twitter that says, sympathy, the look I detest most. It reminds me that I'm less than who I once worked so hard to be. I put my feet on the ground. I grit my teeth through the pain. I realise no one can appreciate an accomplishment if they don't know the battle. So it's really important that we start to understand the person sitting in front of us, the journey that has brought them to be in front of you, and understanding the underlying battle that they've been engaged in. Patients often come to the Persistent Pain Centre expecting us to fix their pain. We are generally the end place that they end up after a long journey with people making attempts to remove their pain. And we have to reset that expectation from day one. Our pain service introduction session talks about we are not here to remove your pain. We're here to actually help you live a quality life with pain. Now, it doesn't mean that pain won't change over time. It might become less of a focus. It might fade away a little bit, but certainly we have to work out our expectations and the patient's expectations are aligned from the start. Otherwise, we're not going to achieve any of those outcomes that are important to the patient. And what I've done is put together some slides that are really focused on the main questions that patients ask us or comments that patients make. The first one is, I'm in pain, so I can't do anything. They're coming into our centre, we're wanting them to improve their function, to work on psychological strategies, and this is something that does come up fairly regularly. So we like to use the metaphor that chronic pain is like the weather. So it can have a really significant impact on your activities and you actually can't control the weather. So for example, you might have plans on the weekend, you're having a lovely picnic in the park, but come the weekend, the weather comes in, it rolls in, it's thunderstorms, it's raining, and you've got options. You've always got options. So one of the options might be, I stay at home. I feel miserable. I stay by myself. I cancel the plans. Or it might be, we actually change the location and I invite people to my place, or we catch up at someone else's place and we move our picnic indoors. Or we might just have fun in the rain. So there's always options, and that metaphor is useful to actually describe the unstable and unpredictable nature that chronic pain can actually be. And maybe the question from our patients is about simplicity, about a desire to do something quite simple to make the pain go away. For example, why can't I just take a pill and make it go away? So a useful example is really focused on central sensitization. And if we look at this image, we have a bathtub sitting in the middle of a bathroom. If we can imagine that the bathtub is the central nervous system and it's overflowing, it's constantly overflowing, with the bathroom being the peripheral nervous system. So you actually can't dry the bathroom till you turn the tap off in the bath and you drain the bathtub. So what we're really trying to say is that we really want to address those nociplastic changes in the central nervous system. So try as you might, you can mop the floor, the water will come back unless the tap is off. So most simple pain solutions, such as medication, might just target that peripheral nervous system, take the pain away for a short period of time, but it won't manage it effectively in the long term. Another question that is really common, particularly when we're doing the psychosocial component of assessments, is why are you asking all these questions? Do you think it's all in my head? And the reality is that a number of patients have probably been told that it is all in their head. So a really nice way of dealing with this is talking about a ballet and looking at the patient and talking to the patient, that explaining to them that they are the lead dancer, and the other dancers are all the issues that hinder or help their management. So if you're on the floor with the lead dancer, you get quite a narrow view, and we can look at that as being the biomedical component of the assessment, very much focused on the person and on their body. But if you actually move to the balcony and you incorporate questions that take into account all the things that help and hinder them, you actually get a bigger picture, and you can identify all the external issues that need to be fixed and the supports that they need to do that. So maybe our patients are saying that they've already tried this treatment. I've seen a psychologist in the past, it didn't work, I'm still in pain. And it's really important that we talk to them about the benefits of a multidisciplinary approach to something as complex as persistent pain. So one of the ways we can do that is to talk about the multidisciplinary approach being similar to building a house. To build a house, you need a concreter, carpenter, plumber, electrician, tiler, but they all need to work together in some sort of sequence, in some sort of concurrency to build the house. So once we've identified all the issues for our patients, an MDT provides all the clinicians they need to address the issues concurrently. So what do you mean by supported self-management? We often get feedback from patients that self-management makes them feel like they just have to go and figure it out for themselves. So it's really useful to talk to them about building a pain toolkit. And we can literally use tools from a normal toolkit to explain that. So we want to create a toolbox for the client. We want to give them lots of strategies and lots of techniques that they can use to manage their pain. And so we can talk to them about, if they're working in a shed, they need a variety of tools. You won't get far with just a hammer. You can't actually build a table with just a hammer. And if you're not careful, you might end up hurting yourself. So you need other tools to complete the job properly. So once patients have got techniques and strategies on board, they've got a metaphorical toolkit, and they can use whichever tool they need on the particular day to manage their pain. So one of the main roles of a psychologist on the pain team is to assist patients with stress management. The slide in front of you shows Paul Gilbert's 3 emotional states model, and it explains well the interplay between stress and avoidance of pain. So chronic pain is associated with overactivity of the sympathetic nervous system. We know that pain makes people stressed, and stressed people have more pain, so it's bidirectional. So it's no great leap then to identify that patients have an overactive threat system, fight, flight, or freeze. What's also the case is that pain patients have an overly active drive system. So this is the system that really seeks out relief from pain or solutions to it. And unfortunately for most pain patients, they will usually use experiential avoidance to cope with pain. So these attempts can be passive, not active in nature. For example, spending more time lying down, booming and busting, increasing levels of medications, catastrophizing endlessly. So as a result of tending to the alarm and avoiding all tasks which may trigger it, physiological arousal remains high. Higher physiological arousal, higher levels of pain. So what are we aiming to do with psychology? Well, Our patients also tend to have a soothing system which is underdeveloped, usually as a result of trauma and attachment issues. What we're aiming for with psychological treatment, whether it's individual or in groups, is to assist patients to strengthen the parasympathetic nervous system and increase their capacity to self-soothe. So we want them to be able to drop into the relaxation response, become less reliant on avoidance, and start to utilise the natural painkillers that we all have in our own medicine cabinet within our body. So as each individual patient is different, there is no one size fits all, and there's no single psychological strategy that will work with every particular person. But we do start from the simplest aspect. People are very stressed, so we start with breathing. And we look at helping them start to reconnect with their breath and ground themselves in the present moment. We utilise a lot of mindfulness meditation throughout our groups, mindfulness groups particularly, but also within other multidisciplinary groups that we offer at the Pain Centre, and certainly within our individual sessions. And utilising ACT strategies of thought diffusion, emotional expansion, and reconnecting with valued activity is really high on our priority list. We'll also look at things like sleep hygiene and really targeting any of those areas that we saw in the previous slide around the different aspects that sensitise the nervous system. So it's multifaceted, multiple strategies, and it really depends on the patient in front of us at the time. And our interventions really need to be targeted to what your patient needs on their journey. It's an interesting statement from Kat Glaw, our patient advocate. She talks about this being a bumpy journey full of twists and turns. And she writes, help me to learn to be my own guide, write my own map, walk alongside me for a while, point out some landmarks so I can find my way back if I'm here again, because I probably will be here again. So that links back to helping them reconnect with what's important to them, but providing that toolkit of strategies and ways of managing the pain, regardless of what it throws up at them. So focusing on a patient's strengths, empowering them to make decisions, helping them see that there is light at the end of the tunnel, helping them find hope is incredibly important when we're working with this particular patient group. And this is another really nice slide that was shared by Claudine Adlington, another patient advocate. She presented this at Alberta Talks Pain 2020, which was held just recently. And it's based on her reflection on what she needed from treatment and what she continues to need. And there's a number of statements here, but the one that I particularly like that really talks to that therapeutic alliance is the statement that says, we are doing this with me, not to me. And on that note, I'd like to introduce a short video from another patient advocate, Gilletta Belton, who talks about what her desire is for allied health professionals working with people with pain.
Knowing now what I know about pain and what has helped me, my advice for healthcare professionals would be first just to listen to us as people first, as humans first, and recognize that what's going on in our hip for me is not the totality of our experience. That how what's happening in my hip impacted the totality of my life, and it reverberated into every corner of my existence. So listen, know us as human beings, and help to build us up rather than beat us down with language. Our words matter, and being told over and over again how weak and unstable and dysfunctional and out of alignment we are, how damaged we are, how broken we are, how much we can't do, makes it really, really hard to get better. And we can change that. We can make the language that we use in healthcare much more empowering and uplifting. We can tell people how courageous they are, how strong they are, because they are in mind, body, and spirit. We can tell them how resilient they are and how adaptable human beings are, especially with new and repeated experiences that change our very biology, and we have some power over what those new and repeated experiences are. And that is so empowering, so empowering. So my advice would be to listen first and to build people up using language that empowers us to see a different kind of possible future. That we can still do the things that make us feel like us. We can still engage with the activities that are meaningful to us, with what matters to us, the people, the places, the experiences that give us a sense of self-worth and purpose and meaning. And I think that's something that we can all do, and I think it would revolutionize pain care.
So I want to leave you with a question. What will your legacy be? So what is the impression you want to leave with your patients? Thinking about everything that we've covered in this very brief session and wondering what you'll do differently next time you come across someone that is experiencing persistent or chronic pain. So if you want to learn more, there's multiple books that are available that will help you understand how to work with patients with chronic pain. There's a number showing on the screen there. We're happy to provide this as a list of resources. So maybe you also want to learn a little bit more online from our patients or from patients that are experiencing pain. One of the most comprehensive websites set up by a person experiencing pain is the Pain Toolkit, with a range of different resources for healthcare professionals, patients. There's podcast links, really worthwhile website to actually link into and gain some better information from patients that are experiencing chronic pain. We also have a couple of blogs. So Keith Meldrum is a Canadian pain advocate who has a blog, and Gilletta Belton, who you've just seen in the video in prior, has My Cup of Joe. So they're both blogs set up by people with pain who are also both on the International Association for the Study of Pain patient advocacy group. Pain Australia is the advocacy group in Australia for people with pain. So there are headings there for health professionals, there's media, there's information about pain. And finally, if you were triggered by Kat Glore and the slides that we've used throughout this presentation, her whole presentation is actually available for free on the San Diego Pain Summit website. It's a really useful thing to spend 50 minutes listening to her story and gaining a really good perspective from the view of a patient with pain. So I'm just going to quickly run through some other resources that are online from professionals. So the Queensland Government has persistent pain resources on the website for persistent pain management services. It also has information about how to refer patients to our pain management services, what the referral criteria are, and what the most appropriate pain centre is in terms of location. But the resources I would strongly encourage you to have a look at. They were updated probably about a year and a half ago, and they're very up to date and really user friendly. The Australian Pain Society supports multidisciplinary pain management in Australia. Again, there's some nice resources on their webpage. There is a draft policy which is soon to be released on the position statement for psychology in pain, which I've had the good fortune to work on with a number of other psychologists around Australia. And their membership is actually really affordable if you're interested in maintaining an interest in this particular area. Pain Chats has advice around pain questions, and it's run by contributors who are specialists in their field. So you can actually read about who's providing the advice, and you can get the most evidence-based information for questions. And Pain Revolution is set up by, amongst other people, Lorimer Mosley, who is part of the Noi group and is a pain scientist, and you heard his voice in Tame the Beast. Their aim is to actually provide education to health professionals in rural and remote areas so that they can be skilled up and they can work with people with pain. But on the website, there are some really good resources there as well. And finally, probably one of the most comprehensive websites, particularly for health professionals, but also for people with pain, is the ACI Pain Management Network. Lots of videos, lots of resources, and a really good place to visit if you're interested in learning more about pain. So that comes to the end of our presentation. We want to thank you for joining us today. And if you do have any questions, we're happy for you to follow up with any of us directly, and we'll aim to provide whatever information can help and support you working with these particular patients. Thank you.